get started on this week's meeting. So today I'm talking about proximal humeral fractures. Just a quick overview today. I'll just give a quick introduction to these, talk about the anatomy involved in these fractures, and then go on and talk about the classification of fractures and fracture patterns, and then talk about treatment, which will be individualised depending on the fracture types. So proximal humeral fractures represent about 5% of all adult fractures, which makes it the third most common. The risk factors tend to be osteoporosis and advancing age. They're more common in older patients, usually following a simple fall. Females have a 2-to-1 predisposition, which is consistent with their increased amount of osteoporosis. 15 to 20% of these fractures have significant displacement or angulation. They do also occur in younger patients, which tends to be from high energy trauma. Just a quick refresh on the anatomy. On the left up here is an anterior view of the proximal humerus with its insertions of various muscles. And the key things we need to remember with these fractures are the insertion of the rotator cuff, with subscapularis being anterior and supraspinatus, infraspinatus and teres minor going along the border from the anterior or superior around to superior-posterior. And the other key thing to remember is the insertion of the pec major on the shaft, which can be a deforming force in these fractures. The blood supply of the humeral head is mainly from the ascending branch of the anterior humeral circumflex artery, which comes off the axillary artery. And a secondary supply comes from the posterior circumflex artery, and also small vessels from the rotator cuff insertions itself. Some studies have looked at vascularity with fracture types, and the basic rule of thumb is that the more displaced the fracture is, the more likely that the vascularity of the humeral head has been disrupted. So classification of proximal humeral fractures was originally described by Codman in 1934, and he described what we're familiar with, the 4 major anatomical segments of the proximal humerus, being the head, the tuberosities and the shaft. This classification was expanded on by Nair in 1970, who described a part being involved if it was displaced by greater than 10 millimetres or angulated by more than 45 degrees. Studies in the 90s looked at inter-observer reliability on X-ray of these fractures, and it was shown that it was poor, but it's improved a lot with CT. And I guess the take-home message with that is that often these fractures can be worse than is appreciated on X-ray, and if there's uncertainty as to the extent of the fracture, it is worthwhile CTing them. There's also, with all fractures, there's also an AO classification, which splits things up as to whether they're extra-articular or articular, and whether the extra-articular ones are either unifocal or bifocal. Just quickly looking through, this is what Codman described with the 4 anatomical segments of the proximal humerus. And then Nair went on to describe the different, what we're familiar with, 2, 3 and 4 part fractures, depending on how many of these anatomical segments have been displaced. And then a quick look at the AO classification. In the top row there is the A-type fractures, which are the unifocal extra-articular ones. And then the second row there shows the bifocal extra-articular fractures, and then the articular fractures, C-type ones in the bottom row. So treatment of these fractures is understandably quite variable, depending on the fracture pattern is the main first consideration. And we have to sort of take all these fractures and the patients on a case-by-case basis, and we also need to look at how displaced the fractures are. The patient age and their demand is quite key. Obviously in younger patients we're looking more at fixation of these fractures. Bone quality, hand dominance and the patient's general medical condition are other things we need to consider when we're looking at fixing them. So starting with minimally or non-displaced fractures, with all types of fractures, it's reasonable to trial non-operative management if there's not much in the way of displacement. And the treatment protocol generally surrounds putting these patients into a sling and starting off with some pendular and passive range of motion. Usually, some people prefer doing nothing for a couple of weeks to let things settle down a little bit. Other people are advocates of starting with early pendular motion. One of the key things is not really starting any active range of motion until we're happy that there is some signs of union so as not to displace the fractures. Obviously, these patients have a high propensity to develop stiffness in the shoulder, so developing some or instituting some range of motion early is one of the key things, but the trade-off is obviously worry about displacing the fractures. So talking now about GT fractures, so X-ray here of a classic sort of GT fracture. There is some controversy surrounding the treatment of isolated GT fractures. There's no studies looked at treatment operative versus non-operative treatment, and a review by Schrader in 2005 showed that there was no real consensus in the literature. Traditionally, it's thought that non-displaced fractures can be treated non-operatively, but a definition of what exactly is non-displaced, there is some debate in the literature about it. It's generally accepted that less than 5 millimeters of displacement is acceptable, although some people decrease this to 3 millimeters in very active patients. So if they're non-displaced, an initial period of immobilization followed by instituting passive range of motion and avoiding active external rotation or abduction, which can displace the fracture in the first 6 weeks. And serial X-rays are needed to see if there is any displacement in that early stage, which obviously if there's gross displacement, it may need to change the treatment to an operative treatment. And also serial X-rays are important because, again, often people will not want to institute active range of motion until there is some sign of union there. Again, stiffness is very common if we don't institute early range of motion, but there is that trade-off with displacement of fractures. And one thing to consider with these patients is there's often a high rate of labral or cuff injuries, even with undisplaced fractures. So if you have a patient who presents and their fracture seems to be well united and they're having ongoing shoulder pain, it is worthwhile getting an MRI done to see if there's any other associated injury. So as I mentioned, greater than 5 millimeters of displacement or 3 millimeters in active patients has been highlighted by Platzer and Bigliani in the past. But there is no consensus in the literature as to what constitutes a displaced GT fracture. What we do know, though, is that a largely displaced fracture or a malunion in a displaced position increases the chance of a decreased range of motion due to an actual block by the malunited bone. So the key in operating on these displaced fractures is to decrease the malunion rate to get that fragment back into an anatomical position, and also to secure the cuff. We need to remember the insertions of the rotator cuff and the GT, and to prevent any abnormal shoulder biomechanics. Treatment can be done either open or arthroscopically, and there's been no studies done to compare these. But basically, the principles surround that there's a need to adequately mobilize the fragment, prepare the bed for it to be repaired to, reduce that fragment down and repair it. And some people advocate, even rather than completely anatomically reducing it, to inferiorize it slightly to maintain the cuff and the biomechanics of that. The fixation method can be done either through suturing the fragment down, especially if it's a small fragment, or if there's osteopenic or osteoporotic bone, or otherwise it can be fixed with 1 or 2 screws with a washer. Again, no research has been done to compare these techniques, and it's generally done on a case-by-case basis. But you need to be aware that using a screw, you need to have a decent sized piece of bone and decent bone quality. Post-operative management, similar to previously, gentle passive range of motion in the first 6 weeks, and instituting active range of motion after 6 weeks. Moving on to two-part neck fractures, such as this one here. So two-part neck fractures, one of the first things to do is work out the stability of this. Now, if the patient is relatively pain-free and can passively or even actively move it without much pain, this is an indication that the fracture is probably stable and possibly an impacted fracture. And obviously we need to take into account the demand and the age of the patient, but these can be treated well non-operatively if they're stable. There's some debate you can also use fluoroscopy to aid in that decision. Unstable fractures, generally what we see with this is medialisation of the shaft due to the pull of the pec major muscle. And a study done in JBJS in the early 2000s showed that displacement of the shaft from the head of greater than 66% should be fixed with a locking plate to improve the patient outcome. Here's an example of a medialisation of the shaft in a two-part fracture and subsequent locking plate fixation. So moving on to 3 and 4 part fractures. So often the 3 and 4 part fractures are lumped in together as far as their treatment goes, and again, treatment is quite dependent on the patient themselves, their age and their function. Historically, NEARS studies in the 1970s showed that these patients did poorly with non-operative treatment, although recent studies, including the one that I presented at Journal Club 2 weeks ago, showed that in low demand patients, non-operative management gives reasonable results, and it avoids any complications with surgery. Operative options in these patients, there is a wide array of options, either through a locking plate fixation, hemiarthroplasty, and there's more use now of reverse total shoulder replacement in these patients. So locking plate fixation is preferable in younger patients to try and recreate their normal bone. The function is shown to be better than a hemiarthroplasty, studies done by Solberg in 2009. A review done by Gardner in 2008 looked at what he thought were the key points as far as locking plate fixation in 3 and 4 part fractures, and having a good medial support. So if there's a lot of comminution on the medial side, this can end up with a poor result, needing an anatomical reduction of the metaphysis. And they also pointed out having an inframedial screw along the medial calcar is one point they thought was key to having a stable construct. Locking plate fixation has higher complication rates than hemiarthroplasty, and the main ones to consider there are AVN, screw perforation either at the time of surgery or subsequently, and loss of fixation as well. Here's an example of a 3-part fracture which has been fixed with a locking plate. The second panel there shows, the arrow there shows the displacement of the GT fragment. And in the third panel there, the long screw there is what they're talking about with the inframedial screw along the medial calcar to provide that medial support. Another treatment option for 3 and 4 part fractures is hemiarthroplasty. Studies have shown that the functional outcome is not as good as a successful ORIF, but it's also shown that a primary hemiarthroplasty, the results of that are better than a secondary arthroplasty for a failed ORIF. So This comes down to, again, looking at our patient and deciding whether or not their function with a hemiarthroplasty would be reasonable enough for them, and doing one surgery rather than attempting fixation and perhaps having to do a subsequent secondary hemiarthroplasty, which may give them a not as good result. So there's a recent review of this. The general consensus was that in older and lower demand patients, a hemiarthroplasty is a very reasonable operation, especially in patients with an initial varus malalignment of greater than 20 degrees of varus with an inability to achieve intraoperative reduction. Marked osteopenia or osteoporosis can be an indication for hemiarthroplasty if there's a worry about how good your fixation is going to be if you go with a locking plate. And also down the bottom there, indications for a secondary hemiarthroplasty after a failed ORIF. I guess one point to take about it is there's often you don't need to make a strong decision pre-operatively, but you need to have the options available to you for either internal fixation or hemiarthroplasty. There's a second point that says there, if you're unable to achieve decent intraoperative reduction, you may need to go on to a hemiarthroplasty. The critical components, obviously, hemiarthroplasty can be a very demanding surgery, and this review by Gardner looked at the key components with a successful hemiarthroplasty. Number one, they highlighted that getting the tuberosities back into an anatomical position and getting them healed is one of the key things to enable ongoing good function of the shoulder. The tuberosities need to be obviously brought down and either sutured to the shaft as well as to the prosthesis. And Lovenberg showed that malunited tuberosities are shown to greatly affect the range of motion. The next key point is the humeral height. So it's shown that shortening the length of the humerus is better than lengthening it. You've got about a 2.5 centimetres from the anatomical position, which you can stray more on the short side. Lengthening greater than 10 millimetres is shown to increase the chance of tuberosity detachment and proximal migration of the prosthesis. And shortening has been shown to be better tolerated up to 15 millimetres. Beyond 15 millimetres, again, showing poorer results. Getting the humeral height right is difficult because of the loss of landmarks in these patients. Obviously, it's a much different operation than doing a total shoulder replacement for arthritis, where you still have the anatomical landmarks available to you. So it can be difficult, especially in the four-part fractures with the tuberosities off, to work out exactly where things should sit. The next point is getting the version right. The average version is sort of around 20 to 30 degrees of retroversion of the humeral head in relation to the shaft, and that's what we should aim to recreate. Straying outside this can increase the amount of instability we have in the shoulder. A study done in the Journal of Shoulder and Elbow Surgery in 1998 showed a reproducible technique for aiming around 30 degrees of retroversion. And that was by aiming the lateral fin of the prosthesis 30 degrees posterior to the bicipital groove. And here's an example of a hemiarthroplasty. Post-op protocol in hemiarthroplasty. Initially, again, the patients are immobilised in a sling. Pendular exercises for the first 2 to 3 weeks, and then starting passive range of motion exercises, and again waiting to do active range of motion when we're happy that the tuberosities are uniting and they're not likely to displace. After active exercises have been instituted, usually after about 6 weeks, they're moving on to isometric cuff and periscapular strengthening. And studies again have shown it's about 9 to 12 months until maximum improvement has been achieved by patients. And with all of these osteoporotic or low trauma type fractures, we should always investigate and manage the osteopenia or osteoporosis. Hemiarthroplasty outcomes are shown to be good for pain relief, but patients rarely get back to their baseline range of motion or function. So patients need to be made aware of that and need to be made aware of the limited goals that we're trying to achieve with this operation. Just quickly onto reverse total shoulder replacement, which is increasingly being used in comminuted four-part fractures especially. One key thing with this, we discussed with hemiarthroplasty the difficulty with getting the tuberosities down and how that's such a key part of that operation. Tuberosity union is not essential in reverse total shoulder replacement because of the altered biomechanics of this type of prosthesis. By medialising in the centre of rotation and inferiorising the humerus, the biomechanics of the deltoid are changed, and this at any given point in the range of motion there's an increased length and tension on the deltoid, which can aid in the range of motion. Obviously a total shoulder arthroplasty avoids glenoid erosion that can be present with hemiarthroplasty. And there's been a recent study shown, which is a retrospective study, which has shown or looked at reverse total shoulder replacement versus hemiarthroplasty, and it has shown that these patients with reverse total shoulder replacements have improved functional scores, as well as improved forward flexion and abduction, but they tend to have a decreased external rotation. Again, it comes down to the surgeon being familiar and happy with the operation, because it is another technically demanding operation. This diagram here shows the difference in the centre of rotation and with the distalization of the humerus, and how at any given place in the range of motion, the deltoid, which is represented by the dark line with the arrow, has more length and more tension on it. And another example, an example here of a reverse total shoulder replacement carried out for a fracture. In summary, with proximal humeral fractures, undisplaced or minimally displaced fractures can be managed non-operatively. In young or high demand patients, we should aim for anatomical fixation. And in displaced 3 or 4 part fractures, there is a variety of techniques we can use. Again, we need to consider the type of patient, all of which can be very technically demanding surgery operations, and all the techniques are viable, and it's a matter of choosing the right thing for the right patient, coupled with the surgeon's experience. And again, to highlight that point, each patient should be treated on an individual basis. And that's it.